Hi guys. Have you ever loved what you do so much that you would do it even if you had handcuffs on? Well, that's kind of the analogy that I'm using with people right now, because I have so many people texting, emailing me, calling me, and they're like, Dr. Aimee, I want to make sure I can still come in for my appointment and you can still stay open. And I'm like, let me tell you something. The only way that I would not be working is if I'm literally in a jail cell. Because even if you put me in handcuffs, I can still figure out how to use Wanda. So right now in California, we have a new set of rules. But all the rules mean, unfortunately, if you're a beauty salon or a restaurant, you're closed. Okay? Clearly you can tell by the same hair I have every single day, and I won't even show you my nails because I always cut them short. This is not a beauty salon. So I feel sorry for the beauty salons out there who are going to suffer right now because of this. Certainly I do. But at the same time, fertility clinics like mine are definitely open. Stores are open at 20% capacity. Fertility clinics are open. No one is shutting us down. So I just want to reassure all my patients and everyone out there. And this is kind of what's going on in the Bay Area right now. So if you're a Bay Area fertility patient, come see me in a jail cell, and maybe then I can even help you. Until jail, I'm still helping people. Okay, so I'm going to get to your questions today, and here we go. Ask the Egg Whisperer. Thank you guys for sending in your questions. I'm going to answer Geralyn's question first. Geralyn says, hi, Dr. Aimee. We did the egg retrieval, and I had 9 fertilized today. 9 fertilized day 1. 6 made it to day 3, though the embryologist said 4 did not look good, and 0 made it to blast. My husband and I are 33 years old. My husband labs and his DNA fragmentation are good. I've been taking NAD, Theralogics, CoQ10, pterostilbene, and a prenatal. Husband's also taking a bunch of supplements too, and this is our first cycle. And I'm not sure if we should try for another cycle or go the egg donor route. This is the thing. I have lupus. I did Cytoxan when I was 17, so I'm not sure about my chances of improving egg quality. Is another IVF cycle worth a try? Finances are so tight, so we'll have to take out a loan for this, but I want to consider my chances. Thank you. Okay, so Geralyn, the fact that you're 33 and did 1 cycle, had 9 fertilized on day 1 tells me there is still hope. There is still a chance that you guys can make a beautiful blastocyst together. I've had cycles like this. I mean, I can tell you, I've had cycles where I get nothing in 1 cycle, like literally like no blast, and then the next cycle I get 4. And if you're someone out there who's listening to this and this has happened to you, like, just make a comment, because literally that is something that happens. There's so much cycle to cycle variability, and I have no idea why. And then I can have the opposite. Like, I can have a patient that has like 4 blastocysts 1 cycle. Next cycle, exact same protocol and no blastocysts. These kinds of things, just so you guys know, are not common. They're not expected, but they do happen. What I would say is they're not uncommon. They're not rare. I'm just confusing myself now. But I think you know what I'm trying to say is they happen. They're not to be expected, but sometimes these things happen, and they don't mean that you need to move on to an egg donor at the age of 33. But let's figure out more about what's going on. Ask the embryologist, how did my eggs look at the time of the egg retrieval? Were they dark? Were they grainy? Were there any physical characteristics that told you that these are not good eggs? Same thing with the sperm. The sperm quality might have been great up until the egg retrieval, but remember my embryodiamonds.com. The diamonds are the 8 things that you need to know about your embryos, and the S in diamonds is sperm on the day of the egg retrieval. So find out, how did that sperm look that day? And then the other thing would be, have you done enough genetic testing? Do you guys have a balanced translocation? Because sometimes this can happen if someone has a piece of a chromosome that's not quite right, even though you look totally normal, and my patients who have that always do, and that's the problem. Like, you can't check this stuff by just looking at yourself in the mirror or looking at your family history, because I have patients that say to me that things like, I have no one in my family that has a genetic problem, so why should I do this testing? And that's the reason why is because we can't look at your family history to tell us if you have the problem or not. So that's why we want to do the testing, especially in a case like yours. And the other thing, if your doctor agrees, is see if HGH is something that your doctor has experience with, feels comfortable with, and would consider using for you. So Geralyn, I would say if you're a patient of mine, don't quite go the egg donor route, although it's so wonderful that you're just going to do whatever you need to do to bring this amazing love into your life. And you guys know some of the sayings that I say. Plan B, this is from Jana Rupp now, is the plan that was meant to be. And you don't need DNA to build DNA is not what builds a family. Okay, well, obviously you need DNA, but it doesn't have to be yours. Okay, so this next question is from Lindsay. Lindsay says, "Hi, Dr. Aimee, my husband and I are getting ready to start our first IVF ICSI soon. Our diagnosis is 0% morphology. All of my tests have come back normal. I'm 32 with an AMH of 4.88. Can you please explain the pros and cons of birth control before starting my stim? As of now, it looks like I'll be in birth control pills for 12 to 15 days before I start. I'm worried this will suppress my ovaries. And I really want to get as many eggs as possible because we only have money for one cycle." Okay, Lindsay, I'm so glad that you shared this question here today because you guys all know my mantra, right? Diagnosis before treatment, the egg whisperer way, and that's the D of the egg whisperer diet. So diagnosis, IVF, endometrial testing, and then transfer. So knowing what your D is, it sounds like you have a really beautiful AMH level. Lots of eggs. So let's talk through, is there a chance that you have PCOS? What kind of workup have you done already? So ask your doctor, have you ruled out PCOS for me? This is the thing. Having PCOS doesn't mean bad eggs. It means having lovely lots of eggs for lots of people, right? But if you have a high testosterone and you do your IVF cycle and things don't work out that well, you might wish someone had said, I wonder if next time we should have addressed this testosterone and brought it down. Same thing with supplements. Like, are you on supplements to support your egg health as you're going through IVF if you have some PCOS-like symptoms? Then, as far as your husband's sperm, 0% morphology, why? Why is it 0%? Is there a varicocele? Have you done sperm DNA fragmentation testing yet? Is his testosterone level low? What is his lifestyle like? So go to ballsmethod.com, go through all of those things on your own, and make sure that you've asked your doctor, have you ruled out a varicocele? Have you ruled out abnormal sperm DNA fragmentation testing? Have you ruled out a chromosome issue? Have you ruled out a low testosterone? Have you ruled out the fact that, not the fact. Have you given him the talk about don't kill your sperm with cigarettes? So I joke and say I don't take care of patients who smoke. That's just to scare people out of smoking while they're going through treatment with me. But to answer your question, Lindsay, your question was truly about birth control pills. So women who have lots of eggs, right? So if you have a lot of eggs, you can use birth control pills for a couple of reasons. Number one is it might suppress your ovaries a little bit to prevent ovarian hyperstimulation syndrome. The other thing birth control pills can do is plan your IVF cycle. So I consider them as FPPs, fertility planning pills. So they actually just keep you at cycle day one, cycle day one, cycle day one until you're ready to start your stimulation. So birth control pills have a lot of benefits, and when it comes to IVF planning, that is one of them, to help plan your cycle, to prevent OHSS, and also if you have some symptoms of PCOS, which I call HOPE syndrome, and my last Instagram post was all about HOPE syndrome, you can kind of go through those things, and you can also go to hopesyndrome.com and kind of read through them and say, do I have that? Do I have that? Do I have that? Then you'll say, I wonder if I should heal, HEAL, my PCOS first before going into my IVF cycle, especially if they're, the way I think about IVF is I get only one chance to help this family. That's it, just one. I mean, I know there are some families where it might take more than one cycle, but if I have that kind of attitude, then I know I'm going to do my very best to educate them as much as possible, and then empower them with the information that they need to make the right decisions for themselves based on their priorities. Okay, guys, this next question is from Kate. And Kate says, "Hi, Dr. Aimee, I'm 30 and I've been in fertility treatment for 1 year. In January, my AMH was 1.1. My doctor recommended I do IVF for embryo banking. That's great. My husband's sperm was A+. We did genetic carrier screening, came back good. I did my first stim in March. My ovaries did not react to the meds like my doctor anticipated. She took my AMH again, and it was 0.3. My next stim was fruitful with another protocol. Are you guys ready for this? We had 17 fertilized, 17 retrieved, 15 fertilized, 5 sent for testing, all came back normal, 3BB frozen day 5. I just finished my frozen embryo transfer and everything looked ideal. My lining, my progesterone, my thyroid. My first HCG showed good news, but my HCG, the second one, decreased 2 days later. Before treatment, I had a similar situation. positive pregnancy test 3 days after a missed period, decreasing HCG 2 days later. What caused an embryo to miscarry so soon? What questions should I ask? Kate, what you described to me is something that is so frustrating as a fertility doctor, because everything can look so good on paper, and then you transfer an embryo, either doesn't work or results in a biochemical pregnancy, which is what you're describing right now. So this is the strategy that I use for patients who've had a biochemical pregnancy before. So I've talked about it before on Ask the Egg Whisperer, and that is the ANGEL method or ANGEL workup. Okay, so ANGEL, we'll break it down right now. So right now, we know that you've had 2 biochemical pregnancies. So I consider anytime I tell someone you are pregnant and then now you are not, it's like one of the most devastating things I could ever tell somebody. It doesn't matter if it was a small, amount of HCG in that moment of time until I told you the level dropped. You felt like you were a mother at that point. And then you'll remember, and everyone's experience is different, the due date, how far along you would have been, months later. And those things, like, they sit with all of us, and they especially sit with me for my patients. And so I never, I get very mad when people have biochemicals and miscarriages and negative pregnancy tests, as you can tell. I never want to have that experience again. When I have that experience once with a patient, I really want that to be the last time. So in a case like yours, I would go through that workup, look at autoimmune issues, right? So do an antiphospholipid antibody syndrome workup, look at the anatomy of your uterus and make sure you've ruled out a uterine septum, hydrosalpinx, look at your nutrition. You've done the genetic testing already, but if you think that doing sperm DNA fragmentation testing is warranted, do that. Remember, looking at the official reports from your IVF cycle can be helpful, because what you might find out is that the sperm quality on the day of the egg retrieval could have been low, and that might contribute to the lack of embryo growth once that embryo is transferred. And then make sure you've ruled out a thyroid problem, diabetes, for example, and look at your lifestyle, your body size, and make sure you're as healthy as you could possibly be before you go into your next transfer. And if you look at all those things, you then might find a strategy that could help keep the next embryo from going, having that same issue. But at the end of the day, truly, these cellular interactions between the embryo and the uterus are completely out of our control. So if you've gone through this strategy that I just presented to you and everything checks out, then you can honestly go to sleep knowing I did everything I can that's in my control to give this embryo the best chance of implanting. And I don't look back with any regrets. And I know I asked all the questions that I needed to ask to feel really comfortable moving forward. So that's really, really important to me. And then, I like to rule out things like silent endometriosis with the Receptiva DX test. I like to look at different protocols for transfer and see what other medications we can use to see if there's a role, for example, for Lovenox. I know not every doctor, believes in that. And then, those are the things that I would talk through with your doctor, Kate. So this next question is from Vicky. Vicky says, "Hi, Dr. Aimee. My clinic has recently redone my AMH for round 5, but not my FSH. Do you need updated FSH scores for IVF doses? I hear you talk about them, ask for them a lot. Are they missing something by not having this, or does it not matter as it's male factor?" So Vicky, that's a really great question, and every clinic is different. So I'll just give you a scenario. So for me, the FSH level in my patients is helpful because most of my patients are over the age of 37. And I just know that some cycles are going to be better than other cycles. And I feel in my experience that a cycle in which the FSH level is lower could potentially give me better eggs than in a cycle when the FSH level is higher. So if I have a patient, she comes in, her FSH level is, for example, 30, then I'm like, you know what? Let's just hold off on doing IVF this cycle and see what next cycle brings. The next cycle, let's say it's 28. But the thing is, I knew she had a previous cycle where her FSH was about 16. I'm like, you know what? The follicle count, I'm really not jiving with it. Let's hold off one more month. Then the third cycle, bam, what's up? Her FSH is 18 and we got 11 follicles. I'm like, let's go. So, tracking and trending levels is important to me because it just helps me understand when the best time to move forward will be for a patient. But I know not every doctor does that or believes in it. I think it's just important to work within the, whatever your doctor feels is like their thing. We all definitely have a thing. You can tell I have my thing, but just because you're not getting your FSH level checked doesn't mean they're missing anything, but it might be an opportunity for you to advocate for yourself and be like, hey people, like, can we check my FSH and estradiol levels before I start stim? I can't find a reason why they would say no. However, if you're on a birth control pill protocol, there's, the birth control pills suppress your FSH. If you're doing estrase priming, your estradiol level will be high and your FSH will be low. So you can't use these levels as true diagnostic tests to guide you about your egg quality. But thank you for that question, Vicki. This next question is from Shannon. Shannon says, hi, Dr. Aimee. Thank you so much for answering our questions. You are a witty, wicked smart lifeline in what otherwise feels like a bleak world of infertility. My two questions are this. I'm 34 years old with unexplained infertility, but also a low egg quality. I suspect endometriosis as well. Let me just take a drink of my really fun cup here. I've done 3 retrievals. First 2 were normal antagonists, Menopur, Folliston protocols, which resulted in 5 blasts for the first, PGS tested, 1 normal, 1 mosaic. 2 blasts for the second, 1 normal. My third retrieval, my doctor switched to a way longer protocol, microdose Lupron flare with higher gonadotropins. We got no embryos in my worst egg quality. Was the wrong protocol for me used, and what should I do next? Also, I'm going into my second transfer. The first transfer resulted in a biochemical pregnancy, and we're putting in our last normal embryo. It's a 3BB day 6 with a MIDA score of 26. What are our chances of implantation success? I'm worried about the high MIDA score. Thanks. Okay, Shannon, so our diagnosis is not unexplained. We know the diagnosis is embryo and egg quality, right? So embryo quality and egg quality are related to age, genetics, and environment. So before you do another transfer, sit down with your doctor and say, what would you do if this transfer didn't work? Like, what are the steps that you would take? I already kind of went through the entire strategy that I would use in a case for a patient who had a biochemical pregnancy. So I would apply the same rules that I just reviewed to your case as far as going through the angel method, doing implantation testing, and then I would strongly suggest reconsider doing 1 more cycle. And the reason is I see you as a young, fertile woman. You're 34 years old. I know thinking about going through a 4th retrieval is probably so hard, but this would be a great time to kind of talk through different protocols, different ways to support your egg quality. For example, were you taking NAD? Were you, did your doctor consider HGH? Is there something about, the egg quality that they saw visually that makes them think that you shouldn't do any more cycles? Probably not. But maybe taking a break and then, kind of figuring out what feels right for you might be a good idea right now. And maybe doing some extra testing, like the implantation testing, is something that you might want to consider before you do another transfer. But a 3BB day 6 with a MIDA score of 26 in the lab that I use, I would quote you a pregnancy rate of around 65 to 70%. That's actually really, really good. And then on the day of the transfer, the embryo is thawed. We're seeing it like sparkling in the sky. I mean, not quite the sky, but there's a video monitor. And then I always look at that embryo and I talk to it. I'm like, you better make me look good. You better make me an auntie here. But sometimes I see signs that the embryo isn't as viable as I had hoped, because sometimes that can happen. And a lot of times the embryo is looking amazing. It's expanding really nicely. It's hatching. It's growing from the time that they thought it until the time we put it in. And so I like to express those emotions and express the findings that I'm seeing with my patient, so she has the right set of expectations as far as what we're going to see as far as an implantation rate. So I use, the language that I'm using right now with you at the same time of the embryo transfer, so the patients truly know what their chance of pregnancy will be with that transfer. Okay, guys, I'm going to move on to Hannah's question. Hannah's question is, hi, Dr. Aimee. I'm preparing for my FET this month, and I'm wondering if you have any top tips for a positive outcome. We're grateful to have 4 normal embryos patiently waiting for us at our clinic. We have not opted in for ERA testing. My lining always looked great. I feel confident in that decision, as our issue is male factor. I feel like I'm doing everything possible for reaching our dream of that positive pregnancy test: acupuncture, moderate exercise, healthy plant-based diet, yoga, and meditation. But naturally, I wonder, if I could be doing more. I've heard many things like avoiding cold foods, eating lots of avocados, red colored foods, lots of sleep. Would love to know your tips. And do you recommend taking an at-home pregnancy test or wait for the clinic to confirm via blood test after the 2-week wait? Hannah, I think you're doing all the right things. I want you to enjoy life. Think of each day as a party, because tomorrow literally is not promised. I would say that, having a healthy lifestyle is important, but avoiding cold foods, eating avocado, eating red foods and pineapple. I jokingly say to my patients, if pineapple actually worked, I'd have a pineapple stand right outside my office, and I would be cutting them for you at the time of the transfer, because that's how important my patient's success is. And I'd be like, here's your pineapple. Don't forget to eat it, okay? And I'd probably come in dressed like a pineapple, although sometimes my hair looks like a pineapple because I got my big bun on top sometimes. So I think you're doing all the right things. I don't think you necessarily need to feel any pressure at all to do the ERA test. But one tip, the ERA test is not related to your fertility diagnosis, right? We know it's male factor. It gives us something called the PET window, the personalized embryo transfer window. So it's your time for when you should start progesterone relative to when the transfer will fall. It's not related to the sperm factor, and it has nothing to do with what your doctor can see on ultrasound. So sometimes people make the mistake of transferring their single best embryo the first time, and then it doesn't work, and then they're left with lower quality embryos, and then they do the ERA test and learn that they should have probably done the ERA test first. So that's my only advice for you. Look at your embryo quality, right? Go through the embryo diamonds protocol, so to speak, or checklist to make sure you understand every single thing about your embryos before you make the decision to do or not to do the ERA test. But I totally support everything that you're doing. Get some good sleep. I wouldn't sweat the small stuff, and I wouldn't try and control like all that kind of stuff. You can have cold food. Okay, this next question is from Anonymous. I wonder if their name is really Anonymous. Anonymous. Okay. Anonymous says, hi, Dr. 80. Aimee, I'm 38 years old with a diagnosis of DOR, adenomyosis, and a history of recurrent pregnancy loss from naturally conceived pregnancies. I also was diagnosed, and you guys, this is actually pretty serious, Asherman syndrome after a 19-week procedure following premature rupture of membranes. Like, that's just heartbreaking. My other miscarriages were early. One had normal chromosomes. It was a 46XY. I've had multiple hysteroscopies with adhesiolysis. My HSG hysteroscopy is now normal. I've had laparoscopic surgery for a partial submucosal fibroid, which came back as adenomyosis in July of 2020. My AMH is 0.2, FSH 13 to 16. I've done 4 retrievals. Typically, I have 5 mature eggs and 80 to 100% fertilized. I did mini IVF, gonal-F and Menopur, 4-cycle Femera, dual trigger. So basically, she's done everything. However, the last cycle, only 2 fertilized with Zymo and ICSI. I've done acupuncture, and the question is, can I transfer a non-mosaic abnormal embryo is basically the question. So that's really, really hard, Anonymous. You've been through so much with everything that you've gone through. And then to say that I am now going to transfer an abnormal embryo is basically what you're saying to someone who's already gone through so much. I would strongly suggest that you not do it. And this is why. Transferring an abnormal embryo will put you at risk of a miscarriage. It really depends on the abnormality. So talk to your fertility doctor, the genetic testing company, and make sure you understand how far that pregnancy could go. Your uterus is telling me, screaming at me, please don't put me at risk for another miscarriage, right? And I know when it comes to pregnancy, we have to accept the chance that anything and everything could possibly happen. That's the hardest part of being a woman who's going to be pregnant and planning it in this way. And I just don't want to see you go through that again, Anonymous. I don't want you to have another transfer, to have it either be a negative pregnancy test or worse for you would be a miscarriage and affect your uterus so negatively that you cannot have another healthy embryo inside your uterus. So in a case like ours, what I don't know is how old you are. And I would suggest thinking about more creative family building options, because you can truly say that you tried everything with your own eggs. Perhaps it might be time to think about egg donation, embryo donation, and other wonderful ways of being a parent that we have available to us in 2020 and beyond. So I would say no to transferring an abnormal embryo in a case like yours. But certainly talk to your doctor, talk to everyone, and make sure that your priorities are met. And I have transferred abnormal embryos for patients. I have. My philosophy is my patients own their embryos, okay? I am your guide. I will transfer any embryo that a patient wants as long as they understand what the risks are, okay? So this next question is from Ash, and Ash is saying, hi, Dr. Aimee, I'm 34, never been pregnant. I've been trying for 4 years. My tubes are clear. My AMH is 6. I probably have PCOS and male factor infertility. My husband had a bilateral varicocele repair in October, and we were planning on a retrieval in January with a fresh transfer. However, I had an in-office hysteroscopy last week, and they saw a 1.5 centimeter fibroid in the cavity near the fundus. I was told that this fibroid needed to be removed before a transfer. My question is this: what is the best order? Should I do the retrieval, freeze embryos, no chance at a fresh transfer, and then have the fibroid removed? Or should I remove the fibroid, do the retrieval, and attempt a fresh transfer? I asked this because I don't want the fibroid to grow back, and I read that IVF meds can cause fibroids to grow. I was told by my doctor that it doesn't matter what order we decide on, I just want the best possible outcome. Help. Thank you. Okay, Ash, here's what I would do if it were me. I would say, da na 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 na. You guys, what would you do? What would Aimee do? So in a case like yours, I would just say, number one, how many kids do you want? You guys know my 3 questions. What is it going to take, and am I willing to do it? I would say we know that doing IVF makes sense because of the male factor. You know, if there was a sperm issue saying that there was male factor infertility, I don't know that you need genetic testing of your embryos or and a frozen embryo transfer. But if you want to give yourself the highest chance of pregnancy, you're just going to do things my way. And my way would be do your IVF cycle, prepare your endometrial lining, and then do a transfer. So for your IVF cycle to be amazing for someone who has lots and lots of eggs, doing a frozen embryo transfer always makes sense, okay? Like, you don't want your doctor to feel like, oh, I can't trigger her the right way and get enough, mature eggs for her because we're going to do a fresh embryo transfer. When your AMH is 6.4, you're someone who's like, holy smokes, smoking hot ovaries, lots and lots of eggs, right? And so you don't want to have ovarian hyperstimulation after an embryo transfer. Get your embryos made, prepare your uterus, get the fibroid out. 1.5 centimeters, you guys. Super, super tiny. Tiny little fibroid. That's a fun fibroid to remove. Fun. And then the next cycle, you can transfer. That's kind of what I would do. I would think of it as a 3-step or 3-stage or 3-month plan. Step 1, IVF. Step 2, remove the fibroid. Step 3, transfer. Otherwise, you're just delaying things, and you're going to need, it would be nice to have a month off in between your retrieval and your transfer anyways. Okay. That's my answer. I'm sticking to it. Okay. This next question is from Annie. Hi, my embryos went from 13 collected, 11 mature, 9 fertilized, 8 on day 3, 9 with 1 9-cell, 2 8-cells, and nothing to transfer on day 5. What could the reason be? Or what test can me and my husband get done? Is it a sperm or egg issue? Okay. All advice is greatly appreciated. Okay, so let's go through the embryo diamonds, right? So the D is, what day did your embryos, stall on? It sounds like day 3. The implantation rate, it seems like they were okay quality. And we don't know if they're abnormal. We don't know if they're mosaic. We want the official reports. And on the official reports, we would like to know the egg quality on the day of the egg retrieval. Like, how did they physically look? The sperm quality on the day of the egg retrieval, how did that physically look? Okay. And then we want to know, I already kind of mentioned that. So here's what I would do in a case like yours. Number 1, how old are you? Okay, so we know embryo quality has to do with age, genetics, and environment. So knowing how old you are is really important. So if you're over the age of 40, I would say this happens, this is normal, keep going. You just never know when you're going to get a blastocyst. Like, this is normal stuff. However, I still just wouldn't assume that it's age. So I would consider making sure you've done enough genetic testing for both of you. Do a chromosome analysis for both of you. And then the other thing would be sperm DNA fragmentation tests, I think would be really helpful. I have read about and seen cases that in which calcium activation can help with blast formation rate. Ask your doctor if that's something that they have seen and they believe in, and they can apply to your eggs before your next egg retrieval. And then make sure you're taking supplements to support egg and sperm quality. And I talk a lot about the supplements, so I know that you guys already know what they all are. But those are kind of the things that I would do. And I would just look at your body size, your health status, and make sure that you're both as healthy as you could possibly be before your next cycle. But Annie, I feel like anyone who has 11 mature eggs can still have a chance for pregnancy in the future, and you're asking all the right questions. So go get those extra tests and do all the things that or talk to your doctor. You can't just do all the things that I say. Talk to your doctor about these suggestions and see what they think with you, and you guys can do them together. Okay, so this next question is from, this is so fun, Pinky and the Brain. I love the names that you guys are calling yourselves. I'm starting my 4th IVF cycle, 39 years old, no pregnancies, just started later in life. My AMH is 1.5, AFC 8 to 10, taking Synthroid 75 micrograms. In my first cycle, it was an antagonist, was canceled due to lead follicles. In my second cycle, I had 12 eggs retrieved, 9 mature, 7 fertilized, 6 day 6 blasts, 5 PGT abnormal, 1 mosaic. Third cycle, same protocol, 3 fertilized, 1 normal. My doctor was focused and discussed a lot about my estrogen levels during the latter parts of stim and how plateauing and dropping to the latter part can mean changes in egg quality. In the first cycle, my levels plateaued and slightly dropped 2 days before the egg retrieval. He felt that may be a suggestion that there could be an egg quality issue. In the second retrieval, I had a slight drop a day after the egg retrieval. What does the estradiol levels signify? Other than closely watching levels and triggering right before plateau on upswing of levels, any way to predict the drop? Okay, Pinky and the Brain, this is the thing. One of the questions I would ask you is, when did you start the antagonist? So sometimes the ganirelix or the cetrotide can cause this drop in the estradiol. I would also look at the size of your follicles. Have the follicles kind of slowed down as far as their rate of growth? That can affect things too. So estradiol levels are really helpful in that they guide me to tell me the protocol to use for the trigger shot instructions as far as how much HCG, should I add Lupron. Estradiol levels also kind of give me somewhat of an idea as far as how many mature eggs to expect. Things that are bad for the estrogen, in my mind, if the estrogen level literally goes down, and sometimes that can be a bad sign about egg quality. And I would always talk to the patient in that moment and share with her my concerns to make sure she is fully on board with moving forward, understanding that this might not be the very best cycle. So that's kind of how we use estrogen levels. And sometimes the progesterone level can help us, the LH level can help us as we're trying to make decisions about what to do in someone's cycle. Okay. So Allison's question is this. Hello, love your show. I just turned 35 last month with no children. My hormones are all normal. My AMH is 12.3. I have PCOS, but with metformin supplements, diet, and lifestyle changes, I have a BMI of around 28, and my health is great. I tried for 15 months with an unhealthy man who refused to have a semen analysis. Yes, we don't like those kinds of guys. While torturing myself with Clomid, Femara, and Ovidril with no success. With good tushy findings, I don't think I was the problem. I'm now single. My question is this. My local fertility doctor offered to do IVF with donor sperm on me, giving me a 75% success rate the first time. They wanted to do a luteal Lupron protocol on me. Then I went to a different clinic and they said they don't do come on, guys. The luteal, come on, focus, Aimee. The luteal Lupron protocol, and they are only using very low dosages on me because I'm at risk for OHSS. What is the difference? I'm afraid I'll end up with no embryos, and I can only afford to do IVF once. Please help. Okay, Allison, the clinic that you are referring to makes me think that you're going to be traveling out of state to go to that clinic. When you're traveling out of state, they're not going to be seeing you the entire time. They want to make sure you're safe. They don't want you to be on a plane and then drive right to an emergency room. So they're going to use less stim because you have so many eggs. And honestly, even if you were here down the street from me, I would do the same thing. I would avoid the luteal phase protocol, the Lupron, luteal. Clearly, I can't say two words together that both start in an L today on Tuesday, but maybe tomorrow I will be able to. And I do think that that is very smart, like wicked smart for them to do, because then they can use Lupron to trigger you. And if you're on a Lupron protocol, you can't use Lupron to trigger because you're already using Lupron to suppress ovulation, so you can't also use Lupron to trigger. So that's the reason, from a safety standpoint, it makes perfect sense to do away with that Lupron, to introduce lower stem, get seen frequently and early so that you have plenty of time to increase your dose of medications. It's really that simple. And then your doctor still has the flexibility to use an HCG trigger and Lupron for you, keep you safe, get tons of eggs. And the thing is this, you're young, you're not even 35. Your AMH is through the roof. It sounds like you're taking great care of yourself and you've healed your PCOS. So I would say, I agree with your doctor. I bet you're going to have a really high chance of pregnancy, just like the last doctor said, at 75% success rate the first time. And I would not be surprised if you're successful the first time either. Okay. Oh, and Allison just sent another question in saying, correction, my BMI is 25, not 28. No worries. Okay, this next question is from Rebecca. Rebecca says, Dr. Aimee, you've been amazing and very helpful. Thank you. My husband and I have been trying for 14 months. I'm 26, he's 29. He has conflicting semen analyses. Dun, dun, dun. One showing low counts and one normal. We're debating doing IUI or IVF. I have an AMH that's high, and I don't hear of many successes with IUI. Thank you. We need more doctors like you. That's very, very sweet. Okay, Rebecca, let's do a tiebreaker semen analysis, right? Like, let's see what it looks like a third time. And then even better, let's not judge a book by its cover, and let's do a deeper dive. I wish I could say that a better way than deeper dive. That sounds really, really weird. Looking at the sperm DNA. So maybe order the sperm DNA fragmentation test and have that test be your tiebreaker, right? So you got the 2 semen analysis, introduce the sperm DNA fragmentation test, and allow that test to guide you. If the sperm DNA fragmentation is borderline low, or if the sperm DNA is borderline abnormal, then I would say it makes sense to just go right to IVF. If the sperm DNA is not good, no matter what, try and improve it, but maybe IUI will not be as helpful for you until it's improved. And depending on your timeline with when you want to start your family and start having babies, it might make more sense to do IVF. But let's kind of narrow down the diagnosis. Let's learn a little bit more about sperm. Do all the things that I say. Wouldn't that be awesome if everyone just did everything that I said? I wish. Okay. This next question is from Maria. Maria says, I'm female, 36, tushy normal. And I love that you guys just tell me that, like tushy normal. Like, I just love that because I totally know what that means. AFC is 16. And for those of you who don't know what that means, go to tushymethod.com. You can sign up for my tushy course at eggwhisperschool.com and watch all the videos and read the articles that are associated with that. My AMH is 3.1, male factor infertility due to varicocele. Semen analysis is like this: 14 million, 40% motility, 3% morphology, 23% DNA fragmentation. Balls method, done and normal, minus the stuff that I just mentioned to you. My goal, I want the best results possible because I want to bank enough embryos for multiple children. Love you. Concern, higher DNA fragmentation proven to hurt results. Let's solve this. Question, which sperm selection method do you think should be used and why? Number 1, 100% zymote, then ICSI. Number 2, 100% PICSI. Number 3, 100% zymote and then do PICSI. Number 4, 50% density gradient with PICSI, then 50% zymote and PICSI together, or something else. This is the background. Many patients with DNA frag issues are reporting success with zymote and PICSI together. I saw an embryologist take on the zymote and PICSI combo. She seems anti-zymote and has a competing company and has never used PICSI and zymote together. My lab hasn't used zymote, but they are willing to do it at my request. Okay, Maria, this is the thing. You might just create a zymote revolution at the IVF lab that you're using, because they're going to see how gorgeous the embryos are that you have and be like, this is our new thing. I know embryology lab directors that have been using zymote for over a year, and they swear that the embryo quality is so much better. I tend to use Pixie for most of my cases, but there are absolutely so many of my cases that I'm doing both Zymo and Pixie. So in a case like yours with 23% DNA fragmentation and the good counts that you're sharing, 14 million, 40% motility, my gut is Pixie is probably enough, or Zymo is probably enough, obviously with ICSI. But if you want to be super creative, then you might want to just choose option number 3, 100% Zymo, and then do Pixie. That's something that I've done in some more challenging cases, and I've seen the results that I wanted for the patient. So consider doing that. And if not, I honestly don't think you could go wrong with just Zymo or just Pixie. If your clinic has more experience with Pixie, maybe choose that over Zymo. I think it might be hard to have them do something that they've never done before for the first time in your case. And if they could somehow practice with it before your case, that would also be nice too. Okay, this next question is from Christina. What questions should I ask my PGTI lab to ensure they are quality? For example, should I ask to see a sample report beforehand? Ask them how specifically they will define mosaicism. Ask them what their definition of abnormal is. I read that many labs will report mosaic embryos as abnormal and simply don't tell patients and sometimes even doctors. What questions should we be asking beforehand? I want as much information as possible. What should I ensure the PGTI lab is giving me? Christina, you have to ask your doctor. It's actually the doctors. Can you believe this? I'm actually saying it's the doctors that tell the genetic testing company what to report. They tell the company, I don't want my patients to know if their embryos are mosaic or not. And then you have to be smart enough to pick up on that. And that's just so wrong. So ASRM came out with a statement saying that every IVF doctor that does genetic testing should be sure to share their protocol for reporting and transferring mosaic embryos as of immediately, right? And guess what? It's still not happening. So that's why I'm talking about this all the time on my show, on my podcast. I say it over and over. It's the M of the embryo diamonds, the M, guys. So that's why I want people to know this stuff. And this is a great question. It's not a question to ask the genetic testing company. It's a question to ask the doctor, but you can certainly double check and cross-reference and ask both. Ask your doctor, what is your protocol for reporting and transferring mosaic embryos? And if you don't like what they're saying, ask the genetic testing company. If my doctor will not tell me which embryo is mosaic or not, will you? And a lot of times the genetic testing companies will say, we will do, your doctor will tell us. But honestly, we're getting to the point where genetic testing companies may tell patients, even if the doctor won't, but you won't know unless you know to ask. Okay, so you can't, I have so many patients that they just tell me, oh yeah, I was told I had 5 blastocysts, 1 normal, 4 abnormal. And I'm like, were any mosaic? And they're like, well, we didn't see the report. I'm like, what do you mean you didn't see the report? Well, no one told us that there was a report that we could even see. And I'm like, okay, well, that's the O of embryo diamonds. Get your official reports. Schedule a post-IVF consult with your IVF doctor and go through them. And then if you have any follow-up questions, you just say, I'd like to review everything we just discussed today, and I'd like an opportunity to sit with it and then come back and see if I have any questions so I feel really comfortable about the decisions I'm going to make moving forward. It's a great question. So this next question is from Grace. Grace says, I'm 39 years old. My AMH is 3, tubal factor infertility. My follicle count varied between 14 to 18. My last protocol, 150 menopure, 300 gonal with cetrotide antagonist. By day 10 of stim, I had less than 8 follicles over 15 millimeters. Is this normal? What could be the cause of the follicles not growing, and what could be done differently next time? Okay, so Grace, what I want to know is, what is your AMH level? If your AMH level is around 0.8, I would say that is a great egg count for someone whose AMH is 0.8. But if your AMH is really like 1.8 or 2, then you're right. Like having 8 follicles growing feels like a lower number. Looking at the dose of medications that you were on, that is a really healthy, good dose. And forgive me, Grace, you did tell me what your AMH is, and you guys are like, knock, knock, who's there, Aimee? Grace told you her AMH is 3. See, sometimes I have to be reminded. So with an AMH of 3, that's not quite consistent with the follicle count of 14 to 18. So I'm thinking, let's repeat your AMH because just something is not quite adding up. And then it is normal. So I've talked about that IVF pyramid. So if you go to my blog and just put into the search engine IVF pyramid, you'll see exactly what I'm talking about. it is actually quite normal because we're human beings. And this is what happens for us along the way as we're going from follicles to mature size follicles to the number of eggs retrieved, for that number to get smaller and smaller and smaller. And that's really annoying because like in school, we think of 100% as like getting 100% of the eggs. And when it comes to IVF, we feel like if the numbers change from 14 to 8, we just feel like we got a D on the test. And it feels like we're losing something and something's being taken away from us. And it's very cruel when that happens because you just, gosh darn it, you just spent like $600 on medications every single day. So that didn't happen. But some of the things that I would talk through is, were you suppressed too much before the cycle started? For example, did you do estradiol premium? Maybe your body doesn't like that. Did you take birth control pills before the cycle? Maybe your body doesn't like that. Should basically, based on your BMI, should you have been dosed at a higher dose based on your BMI, maybe a different needle, maybe doing an intramuscular shot or using a 1-inch needle in the skin? Like those are the kinds of things that I think through when I have a case like yours. And 450 is a very healthy dose of medications, but sometimes some patients just need a little bit more, and that's also okay. So this next question is from Lindsay, and Lindsay says, I'm 32, I have infertility that appears to have been caused by polyps. Polyps were removed, I got pregnant, IUI number 1, but I miscarried at 11 weeks. The pregnancy was chromosomally abnormal. I just finished my first round of IVF and I'm looking ahead to another round or 2. I would ideally like 3 kids. How many embryos should I try to bank? Should I do as many rounds as I needed up front, then move on to transfers? So Lindsay, I totally would do all the work now. I would take advantage of your 33-year-old eggs and not wait, have a baby, and then do another cycle at 35. That is just my bias. Not many people want to deliver a baby and come and see me within 6 months of having a newborn and shuttling back and forth and doing the shots and worried about breastfeeding. How is it going to affect my baby? Will my milk come back if I continue to breastfeed? All that kind of stuff is going to be on your mind. And then I can tell you, if you, let's say, didn't do all the cycles you needed to, you're going to start to worry, like, do I have enough embryos for my future as you're going through the pregnancy and even once you deliver? And then you're going to start to feel like I shoulda, woulda, coulda. However, if you answer these questions up front, just like you're doing, then you're not going to have any fertility regret because you would have planned all this stuff ahead. So my thought is to do enough cycles that you need right now. I would look at the embryo quality that you get and then decide how many embryos you need. So you want to give yourself maybe 1.5 embryos for each pregnancy potentially. So I don't think you need 6 embryos, but maybe 5 would feel like a really good number so that you have enough embryos for 3 kids. However, one thing that you could do is start off with 3 or 4 embryos. And then after the second transfer for your second baby, if you're not successful, then assuming that you're not going to wait more than 2 years, then maybe at that point do another IVF cycle if you don't feel like doing so many right now. So you're definitely doing all the right things by planning your family in this way and creating a roadmap for yourself that includes preserving your embryos. And I think so many people out there don't realize that embryo freezing, kind of like egg freezing, is another way to secure more options for yourself in the future. I feel like there are a lot of companies out there that talk about egg freezing, and certainly I have one egg freezing party where I educate people about freezing their eggs, but I certainly also educate people about freezing their embryos as a way to preserve your fertility. And it's not obviously guaranteed, as we all know, but it just gives you a better option in the future when your egg quality is lower. This next question is from Jessica. Hi, Jessica. She says, hi, Aimee. Hi, Jess. Is ovocytol and myoinositol beneficial for egg quality in someone who does not have PCOS? If so, how long should I take it to see results? Okay, Jessica, first of all, why are you taking it? Okay, so I prescribe it to patients who have PCOS, who might have some metabolic issues and not have PCOS. And I also recommend it for people who have endometriosis sometimes. And I also recommend it sometimes for people who might have egg quality issues. So there are a lot of different reasons why someone might use ovocytol. So figure out, what are your goals? What are you trying to heal? What are you trying to fix? What are you trying to address? What is your diagnosis? And then as far as how long you need to take it, I mean, for my PCOS patients, I check their testosterone and then I put them on ovocytol and then I recheck their testosterone about 30 days later. And then if they're normal, we're good. But if it needs more work, we stay on it longer. So it just kind of depends on what you're trying to fix with the ovocytol and what you're trying to do there. Next question is from Katie. Katie says, hello from London in the UK. Dr. Aimee, I love your show and all you do. I'm 37 years old and my husband is 41. I've been trying for 18 months. I have low egg reserve, and my husband's sperm count is low at 9 million, and average DNA fragmentation is 36%. 6 eggs my first IVF cycle, 2 fertilized despite ICSI. We only did a day 3 transfer, and there was no success, and the other embryo did not get to blastocyst. I think I'm slightly hypothyroid. TSH is 2.6. My doctor says no meds for now. Antibodies are low for the thyroid peroxidase antibody. I'm taking a multivitamin, extra folate, ubiquinol, NAC, vitamin C, D, E, selenium. My husband is taking ubiquinol, Proxide. Any advice on what we can do to try and improve our outcomes for our next cycle in January? I'd love us to get to a blastocyst and feel like there is still a chance. Katie, I totally agree with you. Let's go through the balls method, right? So diagnosis first, so we know that there's a sperm issue. DNA fragmentation is most likely one of the leading reasons, as well as egg quality for sure, but one of the leading reasons why your embryos didn't progress to the blastocyst stage. So what can we do to help the sperm, right? So have your husband convert to Mormonism. No drinking, no partying, no weed, no tobacco, like clean living. And I love Mormons as much as possible, okay? Look at his lifestyle, make sure that he's exercising most days of the week, sleeping well, decreasing stress. I know that's so hard. And we already know that he's taking a really active role in everything because he's taking all those great supplements that he's taking. I would rule out a varicocele, look at his testosterone level and see if he can benefit from a drug like Arimidex, Clomid, Gonalef, HCG shots. Have him go to the urologist and have them check under the hood, do a little good squeeze there and see if there's a varicocele or not. If there's a varicocele, he might benefit from having the varicocele removed. And this might be one of those cases where you want to bring in Pixie and or Zymo into your case to help you have better quality embryos. So talk to your doctor about those things and ask them, what have you ruled out as the cause for my husband's high DNA fragmentation test so you can fix it immediately? And then consider the things that you guys always hear me talk about, like HGH, NAD to support egg and sperm health. Those are the kinds of things that I would have you consider doing if you were a patient of mine. Okay, this next question is from Rebecca. Rebecca says, I'm a 43-year-old young woman today. Good job. And I've done 3 IVF transfers. In July of 2020, I was 8 weeks pregnant with twins, 1 miscarriage, the other in my left tube. I'm sorry. I had to have surgery. In all the cycles, are you guys ready for this? I collected 43 eggs. Wow, in 3 cycles. We just did another transfer 2 weeks ago with two day 5 blasts. One didn't look right to us, but the other, the doctor said it was hatching. This one didn't even take at all. What do you think? We have 2 eggs left. Rebecca, it's just so hard at 43, no matter how many eggs you have. Sometimes they just, we're just at that point where we don't have any healthy eggs left. I would say the fact that you let that last pregnancy just talk to you. So your last pregnancy where you had a pregnancy in the fallopian tube is literally talking to me. And it's saying, look at my other tube, right? That's what the pregnancy is saying. And it's important, I think, especially since you've had surgery now and an ectopic, to make sure that you are reducing the chance that happens again. And the way to do that is an HSG. So even if the doctor looked at your fallopian tube at the time of surgery, the other one, and said everything is fine, I still think it makes sense to do a hysterosalpingogram and see if that tube is abnormal. If it's abnormal, it would be just so heartbreaking to have you have great grammar, Aimee, another ectopic pregnancy. So whatever you can do to minimize the risk of that would be ideal. So ask your doctor if they've ruled out adenomyosis, if they've ruled out endometriosis. Those are a couple of things that can affect the fallopian tubes and can decrease implantation rates and increase the risk of an ectopic. And if you have those things, you would want to make sure you know that before you transfer your last 2 precious embryos. So I wish you all the best, Rebecca. You've worked really, really hard, and I hope this next transfer is your last one before you deliver a healthy pregnancy. Okay, this last question is from Brandy. Brandy says, hi, Dr. Aimee. Thank you for everything. I'm 43, diagnosed with premature ovarian failure at the age of 34. I was told I would need to use donor eggs. We finally decided to do this earlier this year. We got a cohort of 6 eggs. We ended up with 1 day 5 blasts, 5AA, 4 day 6 blasts, 6BA, 6BC, 6CC, and 1 day 7, 5BB. We did not do genetic testing due to cost. In May, we transferred our 5 day 5AA, which resulted in a 6-week miscarriage. Our second 5AA was transferred in late October and failed to implant. We did add Lovenox daily due to an abnormal antiphospholipid antibody panel, which apparently was done in February but was not treated with the first transfer. We're priming for our third transfer now, and we'll do an ERA if this transfer doesn't work. Would you recommend doing an ERA maybe before this transfer due to the grade of the embryos we have remaining, or go with the plan of doing it if this third transfer fails? Okay, so this is the thing. The embryos you have remaining, I'm going to be very open and honest with you, Brandy, may not help you reach your goals of having 2 kids if that's what you want. If you're a patient of mine, what I would say is this: call the egg bank. See if there's another cohort available. Get that extra cohort. This way, your children will be genetic siblings, biosibs, 100%. That's not so important for a lot of people, but I think hearing this up front will help you answer that question. Is it important for my children to be biosibs? I would be heartbroken if you found this out 2 years from now. You're transferring your next embryo for a second baby. You don't have any embryos left that are viable anymore, and you've gone through all of them. And then you're looking to see if that donor has eggs left. So I always talk about this with my patients, no matter what the quality is of their embryos. There's no such thing as quality doesn't matter. Quality certainly does matter. Since we don't know the genetics of the first pregnancy that miscarried, I think looking at your husband's chromosome analysis makes sense to me. I don't think you need to do testing on the rest of the embryos, but I would say, if it were me, your 6BA has a really good chance of pregnancy. The 6BC, 6CC, and the 1 7-day blast, probably not as good. So talk to the egg bank, see if they have another cohort, go ahead and reserve it, and then I would go ahead and do the ERA test, not so much for the ERA part, but so that you can also look at the Receptiva test results and have that guide you. Your implantation window was probably just fine because you did get pregnant and had a implantation. The only problem, obviously, was that the pregnancy stopped growing at 6 weeks. So that suggests to me that your window of implantation was probably right on track. But what we don't know, if there's anything else going on in the uterus that can affect things. It sounds like you've already done the angel workup, right? So you looked at antiphospholipid antibodies, look closely at the anatomy, look at all the endocrine issues that might be, might be there. For example, look at antithyroid antibodies, make sure your thyroid is normal, look at your lifestyle, make sure that you're as healthy as possible. But I seriously think that you're doing all the right things, and I applaud you for working so hard for your family, and I'm so sorry that it's been this hard. I think once you make the decision to use donor egg, you're so ready to just be over with all the nonsense of going through transfers that don't work and miscarriages. And now that you're here, it's just so heartbreaking that you're dealing with this, because I would have wished, and I know you wish the same, that, it would have just been one and done. But for some people, even when you get to the egg donor phase, sometimes things can be a little bit tricky. So I'm glad that you learned about the antiphospholipid antibody syndrome before your next transfer. So great question, Brandy. Thank you for bringing that up. Okay, guys, I'm going to just take a few minutes to go through your live chatted questions. I'm not going to go through all of them, so I'm sorry. You guys know I'm going to be here again tomorrow. Okay, someone asked, what are my stats for women 41 to 42 age group? Are you on SART? And the answer is no, I don't report to SART. I report to my mother. I report to my patients. My goal is to make sure that each patient has the best chance of pregnancy, and I have a lot of patients who get pregnant at 41, 42, and above 43 and 44. Okay, Marianne's question: I had a tiny piece of retained placenta removed in the past. Will my lining have a big problem getting thick enough for an FET? And the answer is you won't know until you try. So you want to make sure that you've done a saline sonogram, hysteroscopy, or both before your transfer. That's what I would do in a case you're like yours. Okay. The next question is my brows look the bomb today. Why, thank you. Next question, my ERA result was 132 hours. Is that normal? The answer is yes. So 132 is pretty average for patients of mine. What does this result mean? The result means that you're awesome, that you just start your progesterone literally 132 hours before your transfer day. So you plan everything in reverse. So there's a cool little website you go to, you plug in your transfer day, the number of hours of progesterone, and you hit enter, and it tells you exactly what time and day to start your progesterone. So it's easy as that. Okay, next question from Grace. I have one blocked tube, but don't know why. Haven't had any infections or symptoms of endometriosis. Should my doctor check for endometriosis? The answer is yes. If you're doing IVF and you have a blocked tube, you want to make sure you're ruling out a hydrosalpinx, ruling out endometriosis. In my humble opinion, that is my approach. Next question is, are vaginal suppositories as effective as oil? And the answer is, in some cases, they are a good option. In other cases, they're not. Talk to your doctor about their recipe for success and why they choose one over the other. In my hands, if a patient of mine is doing vaginal suppositories, I'm very strict. I tell them things like 8, 2, and 8. Skip 1, your efforts are done. No skipping progesterone for you. And if the patient's like, oh my God, I don't think I can do that, then guess what? You're getting a shot, right? No one forgets a shot. Like, you don't forget that you did a shot that night because the shots are horrible. But the vaginal inserts for some people can be horrible and totally disgusting and messy too, and they hate them. So it's just a matter of like figuring out what's right for you and talking to someone about that. And that's the benefit of literally doing the ERA test. It's not so much the actual biopsy and getting results back, right? Because a lot of times those results come back normal, but just knowing how your body responds to the medications, especially the progesterone, can be really, really important. Because I've had patients who get a horrible allergic reaction in the ERA cycle, and I'm like, oh my gosh, thank goodness this happened before I transferred an embryo, because it would have been horrible if I had transferred and then they had this reaction. Next question is, how soon can you take a pregnancy test and what test brand should you use? So there are a lot of really good early pregnancy test brands. I'm not really tied to one of them or the other, but I check for pregnancy 8 days post 5-day transfer for my patients who've done a frozen embryo transfer, even a fresh. So that's the soonest that you can check reliably with a blood test, and that's when I check. However, you can detect blood pregnancy hormone levels even as early as like 4 days post-transfer. But even if you don't, it doesn't mean you're not pregnant, okay? So I would say no pregnancy testing until 8 days post-transfer or later. Next question is, I had my transfer today, was told we'd have high quality embryos because I'm 26. We found out that we had 3 3BBs, 3 3CBs, and I was a little disappointed. Is there anything we can do for better quality? I'm already on CoQ10. So I'm not sure, your embryos are actually, having 3 3BBs at the age of 26 could mean 3 embryos that have normal chromosomes, and especially if they're day 5, for example, those can have a really high chance of pregnancy. So I'm not necessarily ruling out that you have, bad quality embryos, but I would talk to your doctor about what you learned. What do the eggs look like? What do the sperm look like? Do they recommend doing another cycle? Was genetic testing done or not on the embryos? Should you guys do genetic testing to figure out maybe there's something else going on there? Okay. Next question is, can an HSG cause or worsen hypothyroidism? Since the answer is no. HSG should not affect hypothyroidism or your thyroid at all. Okay. Let's see here. Can I go on birth control before getting tested for what is causing recurrent pregnancy loss? I want to go on birth control before we're ready to try again. And the answer is yes. I do think it's okay to be on birth control pills, to do all the testing, get your answers, and then move on for what treatments you should do next. Let's see here. Does CoQ10 and DHEA assist with egg quality? And the answer is yes. For some people, it can help. It's not for everybody. CoQ10 is something that I recommend for everybody, but not necessarily DHEA. Next question. I'm 39. 2 years ago, my AMH was 3.5. Just got my AMH tested again a month ago, and it was 7. Then I asked to get it retested again, and it was 4. Thoughts on why the difference in the AMH level? Yeah. So 3.5, 7, and 4.35. Well, you got lab variation in the middle. So throw out that 7. Your level is probably between 3 and 4.3. That's just called simple lab variation. Next question. When you prepare your endometriosis patients for an FET, when do you start Depo Lupron? Day 21 of the cycle and 5 milligrams of letrozole at the same time? Do you continue letrozole until progesterone? So yeah, I start Depo Lupron typically at the beginning of the cycle with Femera and even Agestin to minimize the side effects. And then I also have them take letrozole through the point where they start progesterone in the transfer cycle. Next question is, I'm on day 12 of my stimulation. Yesterday, my estrogen level was 797. My progesterone was 2. With almost 20 follicles, the biggest one being 15. I was suppressed with Depo Lupron 20 days before. I'm nervous they're not mature. It's too early. I mean, I guess it just depends on the sizes. And you just told me your largest follicle is 15. So you got to keep going. Keep going until your follicles are 18 to 20. Next question is, if you're around 43 with an AMH of 1.4, they said 10 mature eggs. How many eggs should I bank if I want to have a few kids? You suggest 10, 20, 30 eggs. Thanks. Yes, I would say at least 30. Yeah, that sounds crazy. So in order to have one pregnancy at the age of 41, you need over 20 eggs at 41. So if you think about it, at 43, you would need to have like 30 to 40 eggs to even have that chance of one baby. Ugh, it's so unfair. But yeah, you need a lot of eggs. Okay, next question. Good afternoon, Dr. Aimee. I would like to know if any research of patients with DOR in the early 20s. I can't find anything. Yes, Paula, there is a lot of research of patients with the DOR. In a case like yours, be sure to look at Fragile X screening, chromosome analysis, anti-ovarian, anti-adrenal, anti-thyroid antibodies, do a complete autoimmune workup with your doctor, and figure out why. There are lots of genes that we can inherit that cause this. Unfortunately, I don't have a test that I can do for my patients anymore. There was a test, but it's not clinically available anymore. So I would say don't lose hope, freeze your eggs, freeze embryos, whatever you can do to preserve your fertility, do it. Next question is, what are the best supplements for men to take? So there's alphasperm.com. You can use code EGGWHISPER, all caps, for 50% off. I think it's Egg Whisper, or it's Egg Whisper 50. I actually don't remember. You can use either. I don't remember right now. And then there's also Conception XR from Theralogics. You can use the PRC code TUSHY, all caps, for the discount there. Let's see here. Next question is, pregnant and I'm so anxious. I've been worried about the possibility of umbilical cord getting wrapped around the baby's neck. I don't intend to think negatively, but IVF makes you experience pregnancy stress, and I totally agree with you. It totally does. So Ali Domar, look it up, has a book, and it's Finding Calm During Pregnancy for the Anxious Mom, something like that. It's a phenomenal book. And there are a lot of great, meditation experts out there. There's Josephine Atluri. There's Parijat Deshpande. These women have made it their life goals to help women just like you stomp out the ants, those always negative thoughts. And they will teach you strategies that you need so that whenever you have thoughts like that are so normal when you've gone through such a hard struggle, and they'll help you figure out how to turn them off so that you can take deep breaths and not have that anxiety around the things that can cause you literally to wake up in a sweat and have severe anxiety. Okay, so next question. In September and October, I had an AFC of 8. Last year it was 4 to 6. And then in November, when I was ready to do IVF, I had an AFC of 2. Is it normal to drop so drastically? So I would say, these are fluctuations. So this is why I teach you guys about tracking and trending your levels and looking at your ovaries and then figuring out what's a really good cycle for you. So it's like that cycle that had 8 eggs is like, holy smokes, that would have been a great cycle, but it's too late now, and that's okay. The cycle that has 2, you might say, maybe not this month, let's wait, because we know that we've had this experience where it went from 4 to 6 to 8 to 2. Let's just see if there's another cycle out there that's going to be better. Next question from Gigi says, does a day 6 embryo require day 6 of PIO? No. So a blastocyst is a blastocyst is a blastocyst. You transfer a blastocyst at the same time, whether or not it was a day 5, a day 6, or day 7. You still get the uterus ready for that uterus's implantation window as if it's going to accept a blastocyst. Next question is it true that Mucinex works with fertility? So the answer is yes. Mucinex has some role sometimes to help in certain cases, but it is not a fertility medication. It is not a fertility supplement. In some cases where women collect fluid inside the lining of their uterus, sometimes use Mucinex to help kind of remove it. Just like it can help with secretions in our lungs, we use Mucinex as well for the secretions in our cavity, and sometimes that's been a strategy that I've used before in cases where people have fluid in their lining. Next question, what's the difference between AMH and FSH? Easy. AMH tells me how many eggs to expect. The FSH kind of gives me a guide as far as the quality of those eggs. Unfortunately, sometimes we don't know the truth until we go through the real life experience of opening up that box of chocolates, right? So you just never know what you're going to get when you go through IVF. So you want to be prepared for all possibilities. Are you going to have mature eggs? Are they going to fertilize? Are they going to grow? Are they going to be good quality? Are they going to be normal? So you can always ask your doctor, how many do you expect me to get? How many do you expect to be fertilized? How many do you expect to grow to day 5? How many expect you to be good quality? How many do you expect to be normal? And so that's basically your IVF pyramid. And that's the Sparkle checklist. That's a Sparkle method I'm trying to teach you guys with each of these shows, where you're talking to your doctor and making sure that you know this information with each visit. So you're not going back and thinking that maybe things have happened to you that are bad or wrong, or there's something wrong with you, when truly you're just human and you're just doing the very best that you can with all the science that you have at your disposal. Okay, this next question is, I had 9 embryos, 5 normal, 3 mosaic, 1 abnormal. My doctor said 3 mosaic is really odd. What does that mean? Why is that odd? Our first IVF cycle, none of the embryos made it to blastocyst. I would say that's not odd. That's a higher rate than we normally see, but I would say I'm so grateful that they're looking at mosaicism, because that means you won't discard an embryo that could potentially be normal. About 1%, actually I don't know the actual rate, it's less than 10% of embryos that I have seen just off the top of my head are mosaic, but it's high enough that I see it so much. Then I've transferred embryos that are mosaic that have turned into live births, that I want to educate you guys out there about how a mosaic embryo, especially depending on the chromosome, could turn into a healthy pregnancy. So something to talk to your doctor about. This next question is really good. Everything I've read or heard says you're supposed to do an AFC on day 3. My REI doctor says it doesn't matter what day we do it. You're right. Your doctor is right. It doesn't matter. Like, you can do a follicle count anytime, and that tells you the number of follicles that are in that moment. It doesn't necessarily tell you that's exactly the same number that's going to be there in like a week or two, but kind of is like the same. I mean, our follicles don't really change that much from one cycle to the next. Next question is, do day 5 blast biopsy have a higher chance of being normal than day 6 blastocyst? And I would say, I wish, right? Like, I wish the quality had something to do to predict the rate of euploidy, but sometimes like your day 6 embryos can be normal, your day 5s are not, your day 5s can be normal, your day 6s aren't. So quality does matter from the standpoint of the higher the quality, the higher the implantation rate, but I haven't really noticed that the higher the quality, the higher the chance of normal. So that's why we still do a lot of testing. Next question. Hi, Dr. Aimee. Do you recommend 1.5 normals per child for women of any age? Earlier in the show, the woman you recommended this to was 33. So wondering if this is the same guidance for older women as well. And the answer is yes. So your embryo quality is what's going to truly decide exactly what you should do to give yourself the number of kids that you want. So if you have lower quality embryos, you might want to have more than if you were to have higher quality embryos. Someone saying, how do you decide if someone should be on Lovenox post-transfer? So I'll tell you how I decide. If someone has, let's say, an autoimmune issue, antiphospholipid antibody center, if they've had miscarriages and have had all the testing be normal and the pregnancies were tested and also normal, I would say, I want you to consider Lovenox. That's kind of how I decide. Also, if someone has everything negative, no miscarriages, and I've done at least 1 transfer, maybe even 2, and still had no pregnancy, sometimes I think there could be some sort of autoimmune issue between the sperm genes, like they're called HLA genes, and the egg genes, and somehow when the embryos form, that's causing the cellular interactions between the uterus to not be quite right, and sometimes taking Lovenox has been theorized to help, so that's a scenario where I would also consider it in. Next question is, what questions should I ask my embryologist before our FET? Easy, go through the diamonds. What day was my embryo frozen? Excuse me. What's the implantation rate of the embryo? You can ask your doctor these questions too. Will these embryos help me reach my goals of the family size that I want? And do this all before your embryo transfer. Okay, next question. Hi, Dr. Aimee. Day 5 of my 2-week wait after a transfer. What do you tell patients when they ask if they should be feeling symptoms by this point? I say, you shouldn't be feeling a thing, and anything that you're feeling could be totally messing with your head. So you can feel like you're going to have your period any moment, but that could mean that you're going to be pregnant very soon, or you could feel very pregnant, like your boobs could be sore, you can have bad headaches, and you can feel really PMS-y, and truly it could unfortunately be PMS, but it also could be pregnancy, or you feel nothing at all. I make so many phone calls on the days that I'm calling my patients to celebrate the good news, and I have to convince them that they're pregnant. They're like, are you sure? Are you sure? I don't feel anything. So I would say most patients actually don't feel anything. So I wouldn't feel bad if you don't feel anything, especially 5 days after your transfer. Okay, guys, love answering your questions. Thank you guys for being here tonight. I'm going to hop off so that I can get the sleep that I need, finish up all my injection instructions for tonight, call all the patients that I need to call so I can be well rested tomorrow. And I'll be back here tomorrow to answer your questions again. So thank you guys for joining me on today's Egg Whisperer show. And I can't wait to see you guys tomorrow for more Ask the Egg Whisperer. For those of you who are like, wait, I want her to ask a question and mess up the L's, and I'm going to ask her questions that have 2 words that start with the L so she can just get all tongue-tied. I welcome you to asktheeggwhisperer.com, enter your question, and see how you can make me tongue-tied, okay? I love all of you guys. Have a wonderful night. Eat a beautiful plant-based dinner tonight, because that's exactly what I'm going to do as soon as I go home, okay? I'll see you guys later. Have a great night.